been a teacher of mine and a significant contributor to this particular conference. We had lunch late last spring, and I told him that I had been doing some consulting to units that had suffered a suicide, and told him how difficult I found the experience. And he said to me, well, you know, the aftermath of suicide is a very difficult time. And it was at that time that it seemed to me that that might make a good conference. Dr. Havens has made his recent book, if you want to let people know, Making Contact, the uses of language in psychotherapy, has particular relevance for working with this group of patients because it allows different approaches to reaching very difficult patients. And it's my privilege at this time to welcome Dr. Havens.
Dr. Jacobs has attempted to make me responsible for this conference by reminding us how carefully you should choose your words over lunch. In fact, almost anything he says, Dr. Jacobs, makes it into a conference. I hope you'll offer some better suggestions than I was able to. Now, as we know, the focus of this discussion is on the effects of suicide on trainees, institutions, practicing clinicians, and the ways in which they can metabolize these unfortunate results. And we've had 3 papers which have discussed sequentially these settings. I think they're unusual papers in being so well organized, so systematic, in reflecting such a broad experience of this event, and in giving us a considerable wisdom and practical judgment, not only in the receipt of these events, but in their processing for hopefully, our development. So I'm at a loss as to what I could possibly say. I don't want to fuss with the papers. I think they stand very well on their own. I do, however, want to respond in some way to the challenge of the conference and to the structure of these papers. So what I thought I would do is to tell you about 3 suicides in my own experience. A suicide of a patient that I took care of when I was a resident, a suicide that occurred some years ago at the Cambridge inpatient unit where I work, and finally a suicide in my private practice. So in that way, you could do much better than hear someone talk about this, although unfortunately I'll do that too. But you will have a better opportunity than hearing somebody talk about something. You will see somebody as an example upon whom these events have impacted. And you can judge for yourselves the extent to which I have managed to metabolize these events, how much I have managed to learn from them, and whether in fact one has perhaps gained or lost by these tragedies. I'll start out where we finished up by discussing the trainee, that's myself. I will then talk about the institutional case, and finally I'll talk about the loss of a man I tried to take care of some years ago. When I was beginning my outpatient year at the Massachusetts Mental Health Center where I was a resident, I was assigned a patient who had come to the clinic because she was depressed and who was a nurse working at one of the nearby hospitals. This is a great many years ago. I hesitate to tell you how many years ago, so that my memory, I'm sure, has protected me in part from many aspects of this experience. But I can still remember how how poignantly I felt about her. She was an attractive person. She had a kind of wistful forlornness. She was, as I hoped I was myself, steadfast, conscientious, and loyal. Above all, she had the kind of beckoning and receding quality that draws us into the care of other people, perhaps further than we need to or can go. As I have thought about her over the years, and I have often thought about her, showing how incomplete whatever metabolism is that I have attempted in such a matter, although, by the way, I'm not so sure I want to let go of her. And perhaps in a moment you'll guess why. But as I have thought about her over the years, with increasing dimness, two things stand out in my memory. One is a certain darkness that colors all the memories of her that I have. It's as if the whole thing went on in a kind of half-light. God knows, in a half-light of understanding, or perhaps more like a quarter light of understanding. And the other thing that comes back into my mind, if I think about her long enough, is memories of my own mother. Somewhere, for these reasons, I suspect, that these two figures are fused in my mind, whether as a result of her death, because my mother is dead, or because some little light was lit by her, which linked her, perhaps fatally, to my feelings about my mother. In any case, I undertook her care with that kind of eager hopefulness and helpfulness that you can all remember so clearly when you began, and hopefully not all your cynicism and knowledge have washed out of you. The results, however, were not dramatically positive. Indeed, the harder I tried, the worse things seemed to get. And going from making an occasional phone call to me, she made flurries of phone calls. It became such a regular feature of my life that I was almost paralyzed. Later, she made a suicidal gesture, I thought. And my last and most vivid memory of her is when she was hospitalized because of this injury to herself at the Peter Van Brigham Hospital. I remember sitting by her bedside, staring at her. And what I was doing in my staring, I'm very sure, was imploring her to live. Already I detected, I think, that I was somehow losing hold of this young woman. And in that losing, I redoubled my wishing that I might be able to do something to save her from this. Subsequently, she did commit suicide, and then I was left with this. Now, you will say, after these discussions of conferences and reviews, that this great training institution would surely have protected me in some way, or at least have helped me to the valuation of this event. But in fact, nothing happened at all. And I'll come back to that in a moment. This was an entirely silent, secret event, which I managed by myself as best I could. In a moment, I'll suggest to you that, in fact, is the way most suicides end. In any case, it was the way this suicide was handled. Now, I was devastated by this. I was also, however, protected from it, because it never once occurred to me until years later that perhaps I had precipitated this suicide. Perhaps in my eagerness, I think excessive helpfulness, I asked this young woman to go on escalating her demands, challenging me to show her what I would do, how much I loved her. Would I do enough to draw her back from the grave? That thought never crossed my mind until many years later. I think the event began to bring it to me. It was not only some, hopefully, increase in clinical knowledge, but also the death of Marilyn Monroe. She was another wistful, beautiful person that we lost. And if you have read the details of Greenson's treatment of her and some of the other events that surrounded by her death, you may suspect, we'll never know, there are many stories about how she died, but we may suspect that one of the difficulties was that they were too eager to help her. They tried to reach out too hard. They, in a sense, challenged her to test them as to how far they would go in the preservation of this person. It's my belief that many of the sexual events that occur between therapists and patients are precipitated just this way. That is, the two cases of precipitous sexual acting out in a clinical situation that I know about at first hand, both occurred when the patient had essentially threatened the therapist with death. And the therapist had responded not only to that, of course, but to other things as well. And that hoped that by doing this, if doing these things to the therapist, the patient and the therapist, the patient could be drawn back from death. Now, I was far too inhibited, too cautious for such a great adventure to occur to me. And the patient, too, was far too withdrawn and cautious to have ever suggested such a thing to me. But I think deep in our hearts we were struggling to find some kind of experience that would fulfill us both in this kind of pact, you might say, this silent pact of reaching for the limits of our ability to act. I make this point in perhaps too much detail because this is the situation which I think is the most difficult situation we confront in psychiatry at large. That is, knowing when we are doing too much and when we are not doing enough. The next two suicides I will tell you about are really instances where I don't think we did enough. But this was a suicide which I think was precipitated by efforts to do too much. And as I listen to people talking about the emergency room experiences, as I see us agonizing on the wards about suicidal patients, I constantly feel myself on a kind of knife edge of indecision as to whether this is a moment where a person's perhaps histrionic activities should be downplayed and not responded to very much, or on the other hand, where we need to do more to ensure the safety of this person. You all know a great deal, I'm sure, about the literature of the borderline patient, but this always precipitates this dilemma, too much or not enough, in the watching clinician. Now, my second instance is alike and different. Alike in that my second patient slipped silently away. The center of no conference, no discussion, no review, not even a protest from the community or relatives at all. Now, despite the nature of these presentations today, despite the interest we have in the impact of suicide on us, let me tell you my conviction that most suicides disappear unnoticed, without impact on anyone. I would never have believed this except for two experiences that I had. One was comical, and the other was statistical. Let me start with the comical one. When I was working my way through medical school, I used to be an assistant to a pathologist at a community hospital on Long Island in New York. And Dr. Brandis, who was my boss, the pathologist, was the splendid chief of pathology in the winter at the Roosevelt Hospital in New York. And he was a wise and enormously experienced human being. As I watched him over those summers, those 2 summers, signing off the suicidal people whom we had in this beautiful oceanfront community, a frightening number, I noticed that he had never written suicide once on the death certificates. And it eventually became a challenge to me to see to what diagnostic, to what extraordinary diagnostic ingenuities he would be driven by cases difficult to diagnose any other way. The ordinary death was easily enough passed off as a stroke or a heart attack. But one day, an unfortunate elderly sportsman of that moneyed community put the end of a rifle in his mouth, and like Ernest Hemingway, pushed down on the trigger at the other end and blew the top of his head off, which will happen quite predictably under those circumstances. And when Dr. Brandis had gotten through the autopsy, this was something of a whole. After Dr. Brandis got through the autopsy, I said to him, "Well, Dr. Brandis, what are you going to do about this one?" He certainly had a head accident, but I don't think that even your protectiveness of this dear community can extend to downright lying, and he said to me, he said, Havens, he said, I always knew you never had brains enough to become a doctor. This is an easy one, he said. This magnificent sportsman was carefully examining and cleaning his guns when, by some unfortunate accident, the bloody thing went off. And that's the way it went into the newspapers and into the death certificate. So those suicides, which were numerous, essentially disappeared in those communities, at least for all practical medical purposes. Now, my second teaching was statistical. Years ago, and Terry and I did this party together far too long ago to even give the dates on. We were responsible for reviewing all the suicides at the Massachusetts Mental Health Center. Well, when I started to do that, the annual report of the hospital said that there was 0.5 suicides a year. I presume that meant, rather than so there were half baked, it meant that there were one suicide every 2 years. And that was what it had been in the records for many, many years as the official death toll of our great hospital. Well, I decided that I would try to look into this. Well, I didn't have to look into it very long, and I got the number up to 7 per year. So that's a 14-fold improvement in the reporting systems of the hospital, and I don't for a moment believe that my results were complete. What this meant to me was that most of the suicides that occurred went essentially clinically unnoticed. That the patients had disappeared, that they were covered up, or that they occurred outside the hospital, that they were not reported back, and that the community and the family, and we can emphasize this, were very eager that this shameful act should never be publicly known about any person in their own. I think myself this would probably still be the case if it weren't for the advent of the law and malpractice and the rest, where the stakes now fall in our very monetary society in a somewhat different direction. But this is my point, that the bulk of suicides have remarkably little impact, that they fall away from us like the leaves in the fall. Now, I want to give you a brief example of this, although I'm sure you have many from your own experience. We had in the hospital some years ago a woman of middle age who came in because she was depressed, and someone in her outside doctor thought that the treatment needed to be reviewed and that something needed to be done to prevent her suicide. And we had her in the hospital. We did consultations on the psychotherapy. We got to know her quite well. And as time went on, we found that she was depressed, somewhat plaintive, not very pleasant person, who didn't relate easily to the staff or the other patients, was not a major difficulty for us in any way. But as time went on, we tired of her. We tired of our efforts to improve the therapy. We tired of our efforts to reach her. We tired of our efforts to find a new therapist for her, although the old therapist was quite willing that that should be the case. Only one member of our staff reached this woman in a significant way. And that particular member of the staff, unfortunately, had to be away for about a 3-month period at the time of her discharge. What happened? We essentially discharged her without having affected the situation at all. We essentially sent her back exactly where she was, and the doctor, the outpatient doctor who had sent her in, was an elderly member of the community, had essentially tried us, found us wanting, and was thrown back on his own resources. Now, this woman killed herself several months after that. Again, no one noticed. It was not reviewed at great length on the service. The family was essentially non-existent, and the clinician who had sent her in simply breathed what I think was not a sigh of relief, but being an old and experienced person, essentially said that he had done his best, and it had not been possible, even with an organization like our own, to mobilize the interest, ingenuity, and the resources to affect that approach. And I really believe that this is the average, typical example of suicide in our contemporary world. Now, what is the clinical lesson you would draw from that? I'm sure there are many, and some of them have been strongly suggested by these superb papers today. But for me, the central lesson is a paradox. Not entirely different from this knife-edge decision I mentioned earlier between helping too much and not helping enough. But in this case, the paradox is we must somehow anticipate danger when we anticipate it least. We must somehow anticipate danger when we anticipate it least. Now, there was one other finding that we had in our study of suicide at Advanced Mental Health Center that is much more familiar, it's often been referred to. And that is that the patient, when the suicide is reviewed, when it's known about and it's reviewed, and these are not the ones that slip away, but the ones that get reviewed, when the suicide is reviewed, two opposite things are discovered. The first is that suicide is almost invariably a surprise to the helping people. We are almost invariably taken by surprise. And second of all, when you do the suicide review, these psychological autopsies to which Dr. Berger referred, when you do that, when you're through, you then replace by the initial surprise the opposite attitude, in which you say to yourself, my God, why didn't this person kill himself 6 months before? So that between the surprise of the on-the-spot clinician and the sense of fresh surprise that the person lasted as long as they did, at the other end, there is some kind of gap in our understanding that I don't think has yet been illuminated. But out of that has come the practice that I attempt to discipline myself to as much as possible. That is, as I walk around the wards and as I think about my own practice, as I walk around the wards and as I think about my own patients, list of patients that I feel responsible for, as I do that, I always try to concentrate my attention on those people on whom my attention is not concentrated. Because maybe what they have done is they have lulled me asleep. Maybe they have rendered me somehow forgetful, maybe even eager that they go and die. But in some way or other, they have rendered anesthetic, you might say, the attention places in my brain and my heart for them. Well, I have talked longer than you have sat much longer and it's conscionable. Very quickly, let me mention a suicide that occurred in my own practice, not because it adds very much to this, but because it was a unique experience that I thought, in terms of its impact on me and the family, gives a note of irony to these deliberations of ours today, which may be a welcome note this late in the afternoon. I also worked some on one of the state hospital units, and we had on one of these units a dangerous patient that we could not get admitted to Bridgewater, which, for those of you from outside Boston, Massachusetts, is the criminally insane holding environment of the state system. We could not get this man admitted to Bridgewater, but we were very confident he was dangerous, and we had no way of disposing of him, so to speak. And I thought it was unfair to ask a resident to take care of this man, who I think was genuinely dangerous. His family was terrified of him, and he attacked a couple of people rather carefully, not just impulsively on occasion. And so I thought, in my heroic fashion, I thought I would try to take over his care. There was really no choice, in fact, in this matter. And he turned out to be a fairly typical paranoid schizophrenic man who was, however, what I call a soft paranoid, in that you could fairly quickly reach the depressive elements of it, and the paranoid content was rather loose, vague, idealistic, and you could get this thing under fairly control from a paranoid point of view. I won't try to convince you that I could do that, or that there are means to do that, but in fact I believe there are. And indeed, this man became depressed. He became depressed. And in that setting, three things happened, which I think were the immediate recipients of his suicide. First of all, his family, when he was depressed, felt for the first time able to talk to him about himself. They were no longer paralyzed by his fury. And they began to criticize him very harshly. And I didn't know about this until afterwards, but they began to criticize him very harshly. And he became more depressed. In fact, what was happening was the angry mental interject, if you like, the angry mental interject that had once been outside and was attacking him when he was paranoid, had been taken in when he was depressed, and now was added to by the family members that were attacking him. Wow. Second thing happened was that our practice arrangements at the hospital changed, and we were all thrown out of our offices into caravans, and it became extremely difficult to have an office large enough to sit safely with a once paranoid person. So this change in the office arrangements, which with chronically psychotic people, is very significant. psychotic patients over a long period of time. You know, that's a very delicate matter. And so that he became uneasy in the treatment. He skipped an appointment. I had to delay another one. And then he suddenly disappeared. Well, at that point, I was expecting that we were in very serious trouble, and I sent the police after him and everybody else I could find, but he had already committed suicide. Now, the aspect of this not unfamiliar series of events that I want to highlight was what happened when the family came to visit me, his father and his brother. And they came into the office, and to my enormous surprise, that was a suicide I was not so surprised by, but this reaction I was tremendously surprised by. They came into me, and they got down on their knees and kissed my hands. And they were from another country, which was not as bizarre a gesture as it would be if it had been happening in Southampton, Long Island. And they thanked me. They thanked me because, and they told me how guilty they felt that he had died, but that they thought that they had lived for about 10 years under the shadow of the expectation that he would murder them both, and he had nearly murdered them. And he believed that he was gone. Believed that he was gone. And now notice what the implication, in terms of its impact. Notice what the implication of this was. I was not relieved that he was gone. He had never threatened me. I was very disheartened and dissatisfied with myself that he was gone. They were relieved. But so it brought up this question. What had I done? Notice the sequence of events. I had taken him into treatment to keep him from hurting the resident. I ended up keeping him in treatment and to prevent him, apparently, from hurting the family. But the price of that was that he hurt himself, fatally. So out of that experience, maybe you can help me digest it more effectively, out of that experience, I concluded that in some unconscious way, I had colluded in this man's murder. And that I had done it like a good member of the establishment to protect the community and our system from this dangerous and frightening person. That was the impact of that experience on me. Well, so here we have cases, some I think overtreated, some I think undertreated, some perhaps treated as in this last example, in a very peculiar way indeed, in which, as Thomas Zaz would be the first to say, I had become sort of an arm of the law, and carrying out the vengeance of society on this patient, all in the name of doing psychotherapy on a psychotic man. So these three perils, you might say: the peril of overtreatment, the peril of indifference, letting things slip away, and finally, perhaps, a peril that had never occurred to me before until this third case occurred, of the way in which perhaps we are, without knowing it sometimes, the instruments of a social salvation which results in a personal tragedy. Thank you very much.